Okay, let's continue our lecture. So we have discussed types of rejection reactions, so now we need to discuss how can we prevent this kind of reactions, and this is the basis of using some immunosuppressant. So we can immunosuppress patient and minimize the risk of developing some graft rejection, but again sometimes even with intensive immunosuppression patients may develop graft rejection, but actually this happens rarely. So normally I also discussed when patient gets living or deceased donor organs, deceased graft will be much less, I would say, having less potential to survive in terms of, because there are more ischemia going on in cadaveric grafts and more activation of some immune cells, maybe more antigen presentation, and therefore they do have less survival. But mostly during the transplantation, how can we prevent this before we actually transplant to those I would say organs to some patients? So we should do AB0 blood matching, so to avoid hyperacute transplant rejection reaction, and also we should match HLA alleles to donor to the recipient. Okay, so there can't be exact matching, but we should try to match as much as HLA is possible, okay, to avoid these kind of reactions. And even if there's no like ideal matching, we need to use some medications to suppress immune system, and let's talk about this. So mostly we need to use medications that suppress or inhibit or kill T cells to avoid this kind of transplant reaction. I'm talking about mostly acute rejection, okay, because we can't use immunosuppressants to prevent hyperacute, because there are already immunoglobulins in the blood. So when we talk about acute rejection, we need to use medications that block proliferation of T cells or even directly apoptosis of T cells. And you already know that interleukin-2 is very important growth factor for either cytotoxic T cell, helper T cell, also NK cells. So if we somehow inhibit interleukin-2 proliferation, we can also inhibit T cell activation, and therefore if there is no T cell activation, also B cells will be suppressed, because mostly strong immunoglobulins are produced in a T cell dependent pathway, okay, and also we can suppress immunoglobulin production through the interleukin-2 and T cell downregulation. So there are medications which target calcineurin. They are called calcineurin inhibitors. The prototypes are tacrolimus or cyclosporin, and they inhibit the transcription of interleukin-2, therefore decrease T cell proliferation and activation. Also, this happens because these calcineurin inhibitors like cyclosporin bind specific protein. Imagine there's some protein, but like cyclophilin for cyclosporin, and this binding will lead to inhibition of nuclear factor of activation T cells, and eventually nuclear factor kappa beta pathway will be disrupted and interleukin-2 will be suppressed, so there won't be any production of interleukin-2. So a little bit similar effect can have rapamycin or sirolimus. This can also inhibit interleukin-2 production, but through a little bit different pathway, and both can lead to the decrease of pro-inflammatory cytokines like interleukin-2 production, and this will lead to suppression of T cells. So as you can see here, we do have cyclosporin which target calcineurin, and also tacrolimus. Both are calcineurin inhibitors. They will inhibit nuclear factor activation of T cells, NF-κT, and this will eventually lead to inhibition of nuclear factor kappa B and other genes that are involved in cytokine production. Okay, and again, no interleukin-2, no T cells, and T helper cells, cytotoxic T cells. And other than these genes, we can also use sometimes medications like steroids, and as I've already discussed in another lecture, steroids actually specifically inhibit NF-kappa B pathway, and they can also suppress T cells, of course. So other than this, we do have more newer medications that specifically target interleukin-2 to avoid some side effects caused by steroids or these calcineurin inhibitors, and these are also sirolimus, which can target mTOR pathway or target of rapamycin, and also we can directly inhibit interleukin-2 receptor. So even we do have interleukin-2 produced, its receptors will be blocked by the medications, and this can cause decrease in T cells. And these are two newer medications, monoclonal immunoglobulins, tacrolimus and basiliximab, both block interleukin-2 receptor, as you can see here, and blocking of receptor of IL-2 will have same effect like effect caused by calcineurin inhibitors. Okay. Other than this, we do also use some medications that target purine synthesis or nucleotide synthesis generally, and you already know nucleotides are involved in DNA synthesis and to produce any type of cell, including T cells. So if I specifically inhibit, not actually specifically they do have side effects, but generally if I inhibit nucleotide synthesis in T cell, proliferating T cells, they can't be produced, okay? And medications are like mycophenolate, which is commonly used nowadays, like which specifically blocks inosine monophosphate dehydrogenase and decreasing production of purines. So therefore, this decrease of purine synthesis will block DNA synthesis in T cells and also in B cells, and this will cause immune suppression. Same can be true for azathioprine, which can block different enzyme, but this again causes decrease in purine nucleotides and will cause immune suppression because T cells are suppressed. And of course, these medications can have side effects because other than T cells and B cells, they can also affect other proliferating cells like bone marrow, and they can also cause pancytopenia sometimes, or decrease in blood cell type, because erythrocytes can be affected and platelets also, and also there can be any dividing cell effect like GI epithelium and others. So generally we use these medications, but these all are immunosuppressants which can be also used not only in transplant rejection reactions, but any autoinflammatory disorder you may know, like rheumatoid arthritis, severe lupus nephritis, or with any autoinflammatory disorder. We can decrease immune system, so we can easily avoid some activation of immune cells to promote inflammation. And in terms of transplantation, we can easily avoid transplantation or graft rejection, mostly acute graft rejection reactions. So again, here we do have specific targets: IL-2 receptor inhibitors, basiliximab, daclizumab. Also we do have mTOR pathway inhibitors, which is mostly sirolimus. Also we do have specifically calcineurin inhibitors like cyclosporine and tacrolimus. They do have a little bit slightly different mechanism of action, but the resultant will be the same. IL-2 will be decreased during this use of these medications, and patients will have immune suppression. And also we do have specifically nucleotide or DNA synthesis inhibitors, like up there you can see mycophenolate, which inhibits inosine monophosphate dehydrogenase. From biochemistry you may remember this enzyme. And also we do have azathioprine, which can also inhibit other purine synthesis, and therefore the same will be DNA synthesis is disrupted, but also these medications are much more expensive than cyclosporine or tacrolimus. And also antimetabolites are all which I have discussed. So in the metabolism of T cells and DNA synthesis blockers, they are called antimetabolites because, like azathioprine and mycophenolate, will block the T cell proliferation through the intervention of metabolism of T cells, specifically DNA synthesis. And here you can see azathioprine, which will block lymphocyte proliferation through the nucleotide synthesis. And also, as I mentioned, other than transplantation, we can use all those medications in patients with severe autoinflammatory or rheumatoid disorders, okay? Because in all other disorders also we do have T cells involved, sometimes immunoglobulins. Of course, this is autoinflammatory disorder generally. And also we do have mycophenolate mofetil, which blocks purine synthesis through the specific enzyme inhibition, and this will lead to decrease in T cells and B cells. And we can use in the transplant rejection reactions to prevent mostly acute rejection. And again, steroids inhibit generally many type of cytokines other than IL-2, and that is why, as you can see here, steroids do have many side effects and rarely used chronically, like in patients with transplant rejection prevention, okay? Because they do have many side effects, unwanted side effects. Okay, so other than this, I also mentioned that co-stimulation, like normal immune T cell activation, we do have co-stimulatory signals. Signal 2 is a co-stimulation, as you already know. Signal 1 is TCR engagement to MHC, okay? And we also know we do have several types of co-stimulators, actually. CTLA4, which bind to B7, of course, and this will lead to the inhibition of immune response. But normally for the activation we do have B7 binding to CD28. So if we target some medication which is similar in structure of CTLA4, like immunoglobulin or some molecule, we can suppress immune system, and therefore this can be useful in the preventing of transplant rejection reactions. And this medication is belatacept, which is actually analog of CTLA4 bound with immunoglobulin, and this will bind to B7 on antigen presenting cell, and this will prevent engagement of B7 to CD28, and this will suppress T cell activation. And we can use belatacept in combination with other medications, and they are actually as effective as cyclosporine or other immunosuppressants in terms of preventing transplant rejection, but they're a little bit costly, and sometimes we use, sometimes we do not, depending on the patient preference, of course. And also those medications like belatacept will have less side effects than cyclosporine. That's why they cost little bit too much, I would say. So for general overview, we do have cyclosporine and tacrolimus, which inhibit calcineurin, and IL-2 will be suppressed. We do have mycophenolate, which will target nucleotides, guanine mostly, and decreasing guanine nucleotides in lymphocytes will cause their apoptosis, and actually there won't be proliferation of lymphocytes. And also many other. I have not discussed antithymocyte globulin, which specifically binds and depletes T cells and anemia, for example. Also, we do have other medications which target several CD, like CD52, which is alemtuzumab. This actually depletes lymphocytes, rarely used in transplant rejection, but it is used in multiple sclerosis, alemtuzumab, which is specifically for CD52. But again, this MS or multiple sclerosis is also autoinflammatory disorder, and that's why we need to decrease T cell activation. Okay, so those immunosuppressants actually dramatically improve graft survival, and even actually you can imagine that without using those medications, patients may not survive even several weeks or months, because there can't be ideal matching of AB0 and HLA alleles into the recipient from grafted organs. So we must use these medications, and improvement of quality of life is much more increased, and they live much longer than patients who do not use these medications. Actually, we must always use to prevent this type of rejection reactions, but sometimes, but not always, they do have medications, and we need to use these medications like for several years, and they may have some predisposition, development of some infections, and viral infections, bacterial infections, any type of infections, and also some virus mediated tumors or cancers may activate because of immune suppression, because we know T cells or NK cells are involved in the killing of tumor cells, okay? And if we suppress immune system, so like virus mediated tumors, for example cervical carcinoma, which is mediated by HPV, this can proliferate and cause earlier onset of cervical cancer, okay? This is because immune suppression. And also, other than cancers, any type of infection, opportunistic infections, also we see opportunistic infections in HIV and AIDS. This is again because of T cell number decline, and same can be true for this because of medication mediated immunosuppression. And also, other than cancer, like also maybe skin cancer, cervical cancer, and sometimes cervical cancer is mediated by HPV, but also there can be Epstein-Barr mediated proliferation of lymphoid tissue, because immune suppression leads to the more activation of Epstein-Barr virus, and this is type of herpes virus, and therefore this can lead to some post-transplant lymphoproliferative systemic disorder, PTLD, and this can be very severe in transplanted patients. Okay, do you have any questions so far? Okay, yeah. Because even if we match HLA, we can't prevent sometimes this kind of reactions, because there may be involved maybe some other factors that predispose this rejection, and we do not fully understand this mechanism. Okay, so now let's talk about blood transfusion and the AB0 and rhesus blood group antigens. Okay, so mostly this blood transfusion is again form of transplantation where we can use whole blood transfusion, or sometimes specific blood cells like red blood cells can be used, or platelets separately can be transfused. So all of them are generally type of transplantation, and mostly we use during the hemorrhages, and also during some we can transfuse platelets if there's a bleeding and decreasing platelets and so on. But again, normally they can also induce some immune reactions and immune cell activations, because again this is not the type of organ transplantation, but in those red blood cells and in blood product there may be foreign antigens also which are transfused from other person. So therefore we need to understand this AB0 system to avoid this kind of mismatch of blood products, to avoid transfusion reactions. And I'm not going to explain in detail what is AB0 system, but normally when there is a mismatch of AB0 in transplanted patients or transfused patients, mostly this can lead to activate complement, and complement activation will again promote inflammation, and also hemolytic reaction may be a resultant of this, because red blood cells, transfused red blood cells will be actually hemolyzed or disrupted or killed, and this will lead to increase in unconjugated bilirubin and the jaundice and release of free hemoglobin into circulation. This can damage also kidneys, because free hemoglobin is very toxic to the kidneys, and even this can cause acute kidney failure because of tubular necrosis. Okay, so we always need to avoid intravascular hemolysis because of this type of complication in the kidney. And not only in the kidney, there can be disseminated fever, coagulation because of some coagulation cascade activation caused by the cytokines which are produced during these transfusion reactions. Okay, so generally AB0 blood group antigens are several A, B, or 0. So depending on which antigen is expressed, that's how we differentiate them. Yeah, but this is not called suggest you not to use, because in some countries they use different names like 1, 2, 3, maybe for A, B or 0. So this is not correct. You should always use name of antigen. No, like 0 is 1 in Georgia. Yeah, do not remember through this way. Yeah, it will confuse you anyway. Yeah, that's in Georgia. Only in Georgia, but you can communicate internationally to doctor with this way. So all you need to know when we talk about A blood type, so this patient have A antigen on its red blood cell surface, and also those patients also has anti-B immunoglobulin M in the blood. So same can be true for group B. They have B antigen, but they do have anti-A immunoglobulin. So this is why if we transfuse group A having like RBC to the group B blood, this can induce cross reaction, because group A patients do have B anti-B immunoglobulins, and this can cause immediate destruction of those cells. Okay, so this is the basis of this. And also group 0, these do have also anti-A and B, so they are not actually we can also transfuse type 0 blood to those patients, because if we transfuse type A or B, those red blood cells will be lysed or hemolyzed because there are immunoglobulins. AB is ideal because AB patients can receive any type of blood because they do not have immunoglobulins in circulation. Okay. Also, there are different types. Also, we do have rhesus in red blood cells, depending on which sugars are added there, and modification of sugars by some like carbohydrates, and by some fucosin transferase and other enzymes are involved in this antigen expression. And normally I would say all you need to know here is the patients with AB blood are known as universal recipients because they can receive any type of blood types. And also, of course, I'm excluding rhesus type here, and also 0 individuals can be universal donors. Okay, and as you can see here too. But other than this AB0, we do have rhesus classification. Some patients do have rhesus antigen, mostly rhesus D antigen, and some persons do not have. Mostly we need to transfuse. Also, other than matching to AB0, we need to consider rhesus, because if we transfuse to rhesus negative patient a rhesus positive blood cells, those patients will have immunoglobulins against the antigen of rhesus, and this will cause lysis of red blood cells. Now let's see, just brief review, what type of transfusion reactions do we have. So we also would talk about this in terms of hypersensitivity reaction, but let's review some of them. So first is allergic or anaphylactic reaction to transfusion, and you can easily guess because of some immunoglobulin E is produced, and this causes anaphylaxis during the transfusion. So this can be immediate transfusion reaction. And in terms of immunology, patients who are immunoglobulin A deficient, there's a specific disorder, immunoglobulin A selective deficiency. So they do not have immunoglobulin A, but we may have in the blood during the transfusion, like with the blood which is harvested from other person, there may be IgA in the blood. But normally, if I do not have immunoglobulin A in the blood, and if I am transfused with immunoglobulin A containing blood, I may develop immunoglobulin E against this IgA, because this is foreign for me. And that's one of the examples can be asked on exams, that patient is like adolescent woman or man transfused blood and developed some anaphylactic reaction, and also previously this patient had some upper respiratory tract infections and GI infections, so you can easily suspect IgA deficiency, okay, because of this whole mechanism. And this can also cause any type of anaphylactic reaction manifestation, and even shock and death. So we can't always prevent this, but we should know how to treat, like stop any type of general treatment is if any type of reaction develops during transfusion, we must stop transfusion. This is general, but depending on reaction, so in terms of anaphylaxis, we need to use epinephrine and also stop transfusion. So another complication can be acute hemolytic reaction, because this is actually like similarly you can imagine hyperacute reaction. This is also type 2 hypersensitivity reaction, but there is also preformed immunoglobulins or antibodies in the person against some AB0 during hemolysis. This is very toxic to the kidneys and patient. That's why they have flank pain because of kidney damage, and sloughing of the tubules can cause tubular necrosis, and can be cause of severe acute kidney injury. So we need to consider this, and also jaundice from extravascular hemolysis because of increased indirect bilirubin. So another reaction can be just very simple febrile non-hemolytic transfusion reactions, because when there's a transfusion maybe of white blood cells, there can be some cytokines will be released during the transfusion, and those cytokines, you can easily guess, can induce fever, and we sometimes fever we also do have in acute hemolytic reaction, but we need to differentiate acute hemolysis from just febrile non-hemolytic reaction. So there won't be any hemolysis, flank pain, hemoglobinuria or jaundice, and you can easily identify this also with many other manifestations. Okay, one of the, I would say, rare manifestation can be within 6 hours there can be transfusion related acute lung injury during the blood transfusion. So there can be several mechanisms, because during two heat mechanisms actually. Normally our neutrophils may be in the blood, in the lungs, and they can be activated during the transfusion, and they can release some cytokines, and they can actually cause leakage of vasculature, can promote, this is also known as TRALI, transfusion related acute lung injury. Okay, this happens within 6 hours, beginning from the minutes to 6 hours. And how can normally this leads to pulmonary edema or swelling of the lung, but you need to always differentiate this from cardiogenic pulmonary edema. Okay, because when we have patients have cardiac failure, they may have pulmonary edema because of the blood backs up in the lungs, and therefore patients do have increased pressure in the lungs and interstitial space. There will be leakage of the fluid and edema. But normally in those patients, heart will be fine and heart test will be normal. So therefore we can easily say that this is transfusion mediated reaction. Okay, and another immune mediated reaction is delayed hemolytic type of reaction. Okay, so sometimes this is called, also causes hemolysis, but this is delayed because normally, you know, acute hemolytic reaction is immediate because of some AB0 mismatch. But also, other than AB0, we do have minor antigens, which can also be sometimes pre-exposed in some patients, and some patients may do have immunoglobulins against towards some minor, and this can cause delayed hemolytic reaction. Mostly this begins after 24 hours, so we can easily say this is not as severe as acute hemolytic reaction. And beginning from like 24 hours, this is gradual decrease in red blood cells, also gradual increase in unconjugated bilirubin, maybe there may be also jaundice and so on. So you need to also remember these donor red blood cells. This can be antigen of rhesus or minor blood group antigens. Okay, delayed hemolytic transfusion reaction. Also, we do have Lewis antigen. If you may remember, Lewis antigen is involved also in leukocytes for their adhesion, and actually this is previous semester material. When leukocyte migrates into the area of some inflammation, it uses selectins like ENP selectins, and leukocytes have Cialis-Lewis receptors or Lewis antigens for the binding of selectins in order to promote rolling of the leukocyte and therefore migrating into the extravasculature to the inflammatory area. And one of the most important in rhesus antigens, so some of them are, as I've said, rhesus positive, and mostly we all are mostly rhesus positive, but some patients may be rhesus negative. We can actually transfuse to rhesus positive patients either rhesus negative or rhesus positive blood, but we should only transfuse rhesus negative patients to only rhesus negative blood. Okay, and why this is important? So normally this rhesus mismatch can induce some hemolysis in newborns and in fetuses, because when mother or pregnant mother do have some rhesus, I would say negative blood, they may be pregnant with a rhesus positive fetus. Then this rhesus positiveness comes, of course, from father, yes. And sometimes this mixing of blood may happen during some maybe injury in pregnant, or some blood loss during the pregnancy. There may be many complications, or also abortion can promote mixing of the blood with the mother and fetus, and this can induce sensitization of the mother. So mothers will develop immunoglobulins against rhesus T antigen, and therefore the first pregnancy is okay because it takes time to produce immunoglobulin G. But for another pregnancy, if patient becomes pregnant with the same rhesus positive fetus, this immunoglobulin G can be transferred to placenta, and they can damage fetal red blood cells and induce severe fetal anemia and even severe fetal hydrops or swelling, and this will cause actually rhesus hemolytic disorder of fetuses. Excuse me. Okay, so as you can see here, sometimes this is called erythroblastosis fetalis, okay, because rhesus conflict happens in mothers, and we can easily prevent this by just administrating G in the mother who has some risks of developing this immunoglobulin. So here is a mechanism how we can prevent. So if there is a blood leakage in the mother, or any trauma, or any amniocentesis, or any high risk procedures that may increase risk of blood mixing in the mother and fetus, and also after birth, within 72 hours we use anti-D immunoglobulin. This is because the mechanism is easy to understand. So this infused anti-D, or D is a rhesus antigen, anti-D immunoglobulin G will destroy any type of red blood cells, fetal red blood cells that circulate in the mother. So this prevents maternal immunoglobulin G development and maternal immune response activation. So before maternal immune system recognizes those fetal cells, I'm trying to destroy with this medication. So we need to know when to use this and how to use this. Mostly used within 72 hours after birth to prevent this kind of production of immunoglobulins. Okay, and okay, we do have some time to discuss. Also, there may be some minor antigens other than rhesus, and for example, KL antigen can be present in some patients, and this can also induce some severe complication in the fetuses, because again, KL antigens are exposed in the mothers. They develop immunoglobulins against KL antigens, and this may cause the same or even worse reactions during another pregnancy. Okay, this is because of KL antigen, and you just need to know this type of antigen, because sometimes we of course always detect what type of blood the mothers have, but also sometimes if there is a high risk population, like we suspect KL antigen or something, we need to detect this also, because to avoid some deadly complications in the fetuses. And also when there is a hemolysis in the fetus. There is a multi-organ failure because of anemia, and so mostly we use this type of treatment to treat some cancers like leukemias or bone marrow tumors, and also we use for some congenital disorders like severe combined immune deficiency and X-linked or autosomal recessive mediated by adenosine deaminase, or also we use hematopoietic stem cell transplantation for thalassemias and sickle cell disease. So the thing is, we need to replace potentially malignant or disrupted bone marrow with a normal bone marrow or stem cell, so with the pluripotent stem cell which can besides and platelets, and patients will survive. But no, sometimes patients may have complications, which is called graft versus host disease, because you know that before transplantation there is a severe immunosuppression because we use medications to ablate bone marrow, but and this causes a problem because recipients do not have any immune cells in the blood, and sometimes transplanted bone marrow cells or hematopoietic stem cells do have activated immune cells in there. So those immune cells will attack recipient cells, normal recipient cells, like in the same way as we discussed in some rejection reactions. But in this time, graft causes some immune problems in recipient cells, okay, and graft causes immune damage of our recipient cells, and this is called graft versus host disease. But sometimes this effect may be positive in terms of leukemias and cancers, because transplanted graft cells may have some leukocytes in there, and this may cause death of leukemia cells in patients, and this is called graft versus tumor or leukemia effect, and this is one of the positive side of this graft versus host disease. Okay, so other complications, graft versus host disease, again, mature T cells in the hematopoietic stem cell transplant can be activated because host immune system is suppressed, so these graft T cells will cause severe rejection type of symptoms, because graft T cells will recognize MHC antigens or other recipient antigens and will try to attack them. And mostly this happens during the transplantation of hematopoietic stem cells, but also when we transplant large organs like small bowel, lung or liver, there are also abundant T cells, and they also may induce this type of reaction. Excuse me. And mostly if we suspect this kind of disorder, we need to use immunosuppressant, of course, but we do have to, let's briefly discuss, like several slides, we do have two types of graft versus host disease. One is acute, which may develop within hours or within several days, and one is chronic graft versus host disease. In acute form, there is a damage of proliferating skin cells, also proliferating GI cells, also they can cause hemolysis and liver damage, and patients may experience rash, GI diarrhea symptoms, also they may have GI hemorrhage and jaundice, and because of the severe activation of graft or donor T cells that cause damage to the patient's cells. And also there can be chronic form of disease, and this can be very similar to the chronic rejection, because in terms of chronic graft versus host disease, there is a fibrosis and atrophy in some organs, depending on the transplantation. But if we suspect this disorder, we need to use immunosuppressants to suppress donor T cells. Okay, donor T cells must be suppressed because they are culprit in this disorder. We can review this disorder also in tutorial. Okay, thank you.